Today we are going to discuss about cerebellar examination. From head to toe, we will see how to examine each part of the cerebellum. So mainly, just to enlist, probably you all might be knowing, when we start from head to toe, we will start as titubation as one of the components of cerebellar examination. Then when it comes to eyes, there will be nystagmus, for which we will be looking for. Then speech. After that, we will be focusing upon the trunk, mainly truncal ataxia. Then upper limb and some examination in the lower limb. In upper limb, mainly we will look for finger nose test, finger nose finger test, and dysdiadochokinesia. These are important tests we will be doing. In lower limbs, we will look for knee, heel, shin test, as well as pendular knee jerk, and later on we will focus upon the gait examination, in which we will be looking for wide-based gait, and we will ask the individual to do tandem walking. So this is all the entire examination of the cerebellum. Here, what we have to know is, we have to understand the evolution of cerebellum, basically. When cerebellum was developing, initially whatever part has developed, we call it as archicerebellum. It is the oldest part of the cerebellum. And it will mainly involve flocculonodular lobe. And this particular part will take care of the equilibrium and balance of the body. So that is at the center. Next part which developed in cerebellum evolution is paleocerebellum. And it will take care of the tone, mainly tone of the musculature. And what does that involve? Mainly anterior vermis as well as anterior part of the cerebellar hemispheres. So these are the components. And finally, the most recent part of the cerebellum is called as neocerebellum, which is the newest one. And the structures which are involved in neocerebellum are posterior vermis and the cerebellar hemispheres. So these are the anatomical things, and what it will take care of is the coordination. So it will take care of the fine coordination of the movements. So these are the three major components. Whatever we are examining, we'll be looking at all these structures and all these abnormalities. So along with demonstration, we will just mention what is the abnormality and what structure is responsible for that. Coming to titubation. In this individual, we can see there is no titubation. Titubation is antero-posterior or sideward movement of the head, which is not there in this individual. So mainly to maintain our head and neck in the central position, that is called as equilibrium, cerebellum will be doing its action. So which part is involved? If titubation is present, it is mainly dysfunction of the equilibrium. So the oldest part which will take care of the balance, that is archicerebellum. So mainly flocculonodular lobe is the reason for titubation. And here they will ask, in which direction titubation will be there? In cerebellar dysfunction, it will be antero-posterior. One more condition in which titubation will be seen, but it will be sideward, that is aortic regurgitation in cardiac examination. This point we have to remember. So you got to know what is abnormal, that is equilibrium, and what structure is involved? Archicerebellum, mainly flocculonodular lobe. So after titubation, we will be focusing upon the eye examination, in which we will see nystagmus. So we will be asking the individual to look at the finger in a H-shaped pattern. ಬೆರಳು ನೋಡ್ತಾ ಇರಿ ಇಲ್ಲಿ So we will be observing for any nystagmus, and there are some other clues which will hint towards cerebellar dysfunction. We can remember with two O's. One is ocular flutter, one more is opsoclonus, in which eyeball will be rapidly moving in a haphazard way. So these are some clues towards cerebellar dysfunction. And again, nystagmus is kind of equilibrium which has to be maintained by cerebellum. So if there is nystagmus, which part is involved? Again, there is dysfunction of equilibrium, again hinting towards the oldest part of cerebellum, that is archicerebellum and flocculonodular lobe. Then coming to speech examination. Here, if we ask the individual to speak, ಏನು ಹೆಸರು? ಏನು ಕೆಲಸ ಮಾಡ್ತಿದ್ರಿ ಮುಂಚೆ? ಡ್ರೈವಿಂಗ್. ಯಾವ ಊರು ನಿಮ್ದು? ಏನಾದರೂ ತಿಂದ್ರ ಬೆಳಿಗ್ಗೆ? So if you focus upon his speech, we call this as scanning, as well as there is mixture of staccato speech. So what does that mean? Here we can clearly see that he is speaking syllable by syllable, and there are some unnecessary pauses and sudden explosion of few of the words. That syllable by syllable is indicator of scanning speech. So the individual will be scanning for few words. Similarly, in staccato, some of the sudden explosive words will be spoken by the individual. And there will be unnecessary pauses where the individual should not be taking any pause. They will be taking pause. And where they have to actually stop, they will not stop there. So this is due to what? This is because of the incoordination of the muscles which are involved in the articulation. So incoordination word itself belongs to which part of the cerebellum? It is the newest part, that is neocerebellum. So what structures might be responsible for these speech abnormalities? Posterior vermis or the cerebellar hemispheres. So these are the structures responsible. After speech, we will be focusing upon the trunk. So if the individual is able to sit upright or not, that is truncal posture maintenance. And for that, the back muscles should have proper tone. And also, there will be equilibrium, which is responsible for the truncal posture. So in this case, we are able to see that the individual is able to maintain proper truncal posture. So there is no truncal ataxia. If there is truncal ataxia, you have to think that either equilibrium is damaged or the back muscle's tone is not maintained properly. So what are the structures responsible? For equilibrium, again the oldest part. For tone of the musculature, it is the piliocerebellum, that is anterior vermis and anterior part of the cerebellar lobes. So these structures will be responsible. After that, we will be examining the upper limb. In upper limb, we will mainly look for the coordination. So there, we will perform some tests like finger-nose test. So here mainly, we have to instruct the individual to touch at the tip of nose and extend the arm outward. And ideally, they have to keep arm at the shoulder level. So this is the ideal position. So we have to look at both the sides. So in this case, if we observe carefully, we can see that on left side, he is not able to perform it perfectly. So that suggests there is some issue in the left side. So what are the reasons for this abnormal finger nose test on the left side? Individual is not able to maintain the tone of the upper limb. So that might be causing some issues. Or if there is any issue in the coordination, like they are not able to reach the target, in that case also it might come as positive. So finger nose test, if it is abnormal, it might be because of tone problem or coordination problem. So the structures involved might be piliocerebellum or neocerebellum. Now here the thing is, when we are doing this test, when they reach the target, there are some things which we need to focus upon. For example, instead of reaching the target, the individual might stop near the target. This is called as undershooting. If the individual just moves his finger, tip of finger, ahead of the target, that is called as past pointing. So these two words we have to remember, undershooting or past pointing. Why this will happen? Because they will not be able to judge where the exact target is located. This is called as what? Dysmetria, we can say. Because of dysmetria, they will be either overshooting or underreaching. And then what they will do, cerebellum will try to correct these haphazard movements to make them very fine movements. So in that process, what it will do is, even if there is past pointing, it will try to reach the target. So in that process, the individual will move their tip of the finger to make the tip to reach the tip of the nose. So this is what correction which is done by the cerebellum. And this is observed as intentional tremor. Is not actually the tremor, it is just the correction which is being done by the cerebellum to make the haphazard movement into fine targeted movement. So this is regarding upper limb. Now we will do one more test, that is dysdiadochokinesia. So in that, we will be asking the individual to do alternate pronation and supination of the hand. If they are able to do it regularly and rapidly, it is normal. If there is any dysfunction of the cerebellum, this movement will be haphazard, muddy. So on right side, he is able to perform it properly. But compared to right, on left side, this is quite haphazard movement. Okay. So we can say that the movements are haphazard on the left side. So there is some left-sided problem in this. What are the things which this particular test will tell is the rapid movement and the rhythm of the movement. All these things will be taken care by again cerebellum. So if there is any dysfunction, that will suggest cerebellar dysfunction. Now we are performing some tests in the lower limb, mainly knee heel shin test, what we call it as. Again here, we will ask the individual to raise the leg, mainly with the heel. They have to go through across the shin of the other leg. So that instruction we will be giving, and we will be looking for the fine movement there. So what are the things involved here? Mainly tone of the muscle to lift that particular limb and the coordination to exactly pass through the line of the shin. So these two things are involved. If it is abnormal, what does that indicate? Either tone is problematic or coordination is problematic. So what are the structures responsible for tone? Piliocerebellum, that is the anterior vermis or anterior part of the cerebellar lobes. For coordination, it is neocerebellum, that is posterior part of the vermis or cerebellar hemispheres. So these structures might be involved. We will see how to do it now. So with right leg, he is able to perform, he is able to trace exactly through the shin. Now we will see with the left leg. Here we can see the movement is not that fine. So definitely there is some incoordination. And also here we can consider a component of dysmetria, where the individual will not be able to exactly gauge the depth of the distance. So all these components are involved to make it as an abnormal test. So here we can say left-sided knee heel shin test is abnormal. Now we are going to perform knee jerk, where if cerebellar dysfunction is there, it will be a pendular knee jerk. First we will see how to do it. We have to make the individual to sit on the bed and the legs hanging by the side of bed. There, as usual, we will be giving the jerk over the quadriceps tendon and we will be looking for the response. So if you focus here, so here we can clearly see that when we did this particular movement, knee jerk was being elicited, but the oscillations were more than 3. Usually we will call such response as pendular knee jerk, which is again a hallmark of cerebellar dysfunction. So why this particular mechanism will happen is because there will be hypotonia as well as there will be loss of check reflex. That is, when we give some jerk, there will be response, but our body, including cerebellum, cerebrum and all, they have to pause it at one particular point. But because of that loss of check reflex, the individual will be having that pendular oscillations more than the usual. Many authors will consider it as pendular only if the oscillations are more than 3. But ideally, even if it is more than 2, we can say it as pendular knee jerk, which is due to hypotonia and loss of check reflex. So when it comes to tone problem, again it is a manifestation of paleo-cerebellum. When it comes to check reflex, we missed one examination in upper limb, that is rebound phenomena. Again, a hallmark of cerebellar system examination. So here what we will do is, we will be asking the individual to flex the forearm against resistance and we will suddenly remove the resistance. In that case, ideally, whatever the flexion is there, it has to stop so that they can prevent any harm to their face or their own body. But this check reflex will be lost in cerebellar dysfunction, leading to injuries towards face. So we have to protect with the other hand at the face so that these injuries will not be happening. So we'll do it once. Suddenly we will take it off. Similarly on the other arm. So with this test, we can look for the coordination of flexors and the extensors of the arm. So the main reason is incoordination of the muscles between flexors and extensors. So if it is incoordination related, it will be neocerebellum. Now we are going to assess gait. So whenever we are looking at gait examination, first thing is we should ask the individual to stand. So we should look at the stance of the individual. Stance is the attitude in which the individual will be standing. So if you focus in this individual, he is having quite a normal stance we can consider. In cerebellar dysfunction, usually to maintain the balance, if there is truncal ataxia in particular, they will be standing in a wide-based stance. This is the first thing. Then we have to ask the individual to walk. There we have to observe what type of gait it is. So in this one, we could see that the individual is not able to put the steps at proper places. So there will be some interrupted pauses or they will be keeping randomly. All the steps will be kept randomly and the gait in particular we can say it as a wide-based gait. So when to say it as wide-based gait? Whenever the distance between two legs, if it is more than the width of one particular leg, we call it as wide-based gait. So normally when we walk, the distance will not be that much. Suppose if it is cerebellar dysfunction, these individuals will keep it as a wide-based gait. So that was very obvious in this particular case. Then we have to ask them to walk in a straight line. We can choose the already cracked lines in the tiles or we should instruct them to perform in a straight line. That is called as tandem walking. So we will ask this individual if there is any cerebellar dysfunction, they will not be able to perform it properly. Okay. So in this case, we could see that this individual was having lots of difficulty in walking in a straight line. So this is abnormal tandem walking. Again, a sign of cerebellar dysfunction. Usually when you are taking history, if the individual is a farmer, there we should ask regarding this particular history. For example, when they walk in the field, you might see those narrow lines which are made besides that water canal. So there they will be having difficulty in walking that narrow line. That might be a clue in the history itself regarding cerebellar dysfunction. This point we have to remember. And finally, when we think of Romberg's test, here just remember that you cannot be able to perform Romberg's test, because in that case, we will ask the individual to stand first, then we will ask them to stand with both the feet closer. But in this particular cerebellar dysfunction, the individual will not be stand with the feet closure. So we cannot perform Romberg's test properly. So you can just mention in the Gait examination itself, Romberg's test cannot be performed because the individual is having difficulty in standing with feet closer. This point you have to remember. That is applicable only in the case of posterior column disorders. So finally, from head to toe examination of cerebellum particular, we have gone through all these tests, and wherever there is abnormality, we will be able to justify what is the problem, whether it is in tone or equilibrium or the coordination. So based on these, we will be able to recognize which part of the cerebellum is involved, whether it is archicerebellum, paliocerebellum or neocerebellum. So in this particular case, what are the positive findings we got? There was no titubation, no nystagmus, and speech was scanning plus staccato. Both the components were there. But there was no truncal ataxia. But in upper limb examination, there was incoordination problem on the left side compared to right side. In lower limb also, left side incoordination was very evident, and at the gait, he was unable to perform tandem walking, and there was wide-based gait. So based on these positive findings, we can say that there is mainly problem with the tone of the appendicular skeleton, as well as there is problem in the incoordination. So these two will suggest toward problematic paliocerebellum and neocerebellum. So in particular, we can say that cerebellar hemispheres on the left side and the vermis is involved in this case. This is the conclusion of this case.